Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Just a very quick note, the audio for the first 10 minutes of this is not that great. We had some technical issues, and thanks to the wonder of the internet and the kindness of strangers, I have tidied it up, or had it tidied up very slightly, which has improved things, but it's still not that fantastic. So do bear with it, because around about the 10-minute mark, it improves significantly. But also there is a transcript, so there's a link to that in the show notes, so that may help if you need it. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to welcome my guest today, Dr. Koroshetz, who is the director of the National Institute of Neurological Disorders and Stroke. I think I've got that right. Part of the NIH in the US. So there's absolutely loads up for discussion today, and I'm really looking forward to it. So welcome to the podcast.
Pleasure to be here.
Fantastic. So to start with, would you mind just introducing yourself a little bit and just saying a little bit more about what it is that you do?
I'm Walter Koroshetz. I'm the director of the National Institute of Neurological Disorders and Stroke, and we're the agency here in the U.S. at the National Institute of Health, and we fund research on a whole bunch of different neurological disorders, both epilepsy, rare genetic disorders. About 10 years ago or so, we became involved in trying to understand what is the source of trouble and people suffering from myalgic encephalomyelitis chronic fatigue syndrome. We're working with Dr. Fauci's Institute and AID. And then when COVID came, we quickly pivoted to try to develop treatments that can prevent death and neurologic disability. We have infection. And what happened after that is that, many clinics started to take care of people as they came out of intensive care units. But these quickly fell filled with people who were never even hospitalized, but who had COVID or still suffering from long COVID. And then Congress appropriated over $1 billion, $1.15 billion to the NIH to study what we call the post-acute sequelae of COVID. That includes long COVID, but it includes a lot of other things that are related to the long-term health of people after they have COVID. And so with the National Heart, Lung, and Blood Institute, which is really the lead to what's called the Recover Initiative, we've been working to try to understand the problem, and then hopefully move on to its testing treatments to see if they can bring relief to people who are still suffering with these symptoms long after their infection. So that's kind of how we got here there.
Sure, thank you so much. You kind of just touched on it there. Obviously, people with long COVID, we just want someone to come along and give us something that will fix us. That's the goal, right? But in order to get to that, there's so much research and so much work that has to go into it, isn't there?
I think that, the lesson that we learned in working with NICFS was that it's a really hard problem. So the conditions are quite similar, not identical, but very similar. And we come under this group of conditions where people continue to feel bad weeks or months or sometimes years after their infection is over. And that occurred in the past with infections like Lyme disease or Epstein-Barr virus. But now we're seeing it to a degree we've never seen before with COVID. And we've never been able to figure it out, but there's a lot on both, because in the past, people would come to attention years after they had what sounded like an acute infection, but no one could ever figure out what the infection was or if it was really an infection at all. So the situation has really changed now, where now you have millions of people all have the same infection, very similar syndrome, MCFS. And you can actually study people from the time they get infected right through to whether they either make a good recovery or not. So the chance of getting at this underlying problem that vexed us for so long is really right in front of us. And the recovery initiative was really put together to try and attack this problem.
Yeah, exactly. The sort of sheer, number of people all at once, isn't it? Yeah. You mentioned the Recover initiative. I'd love to talk a bit more about that. I mean, I think it's a really big thing, isn't it?
Well, as we were just talking, we thought that this was going to be an easy problem, and people all over the world are studying it, and someone will come up with the answer very quickly. If it's not an easy problem, then that's what we built in Recover to kind of be the backstop. Or should there not be a quick answer? Recover is set up to be kind of a all comprehensive study of this condition. And it has multiple different components to it. As we just talked, one unique ability we have now is actually to enroll people who are now just getting infected. We can then follow them over time to see who makes a good recovery, who doesn't, and then to compare them to see what the difference is. So that's really a unique situation. Certainly we could never do that with MCFS because we just didn't have the numbers. Now we can actually study it right from the beginning. So one of our cohorts is probably the infected cohort. The other cohort, and we actually have, we think of the numbers now, our latest numbers are the acute infected in adult, 3,635 people already enrolled in that study. Then we have people who, have long COVID, and we compare them with people who had COVID but then became normal again. That allows us to compare those two groups, and we actually have now 6,488 of those folks enrolled in the study. Then we got to have a comparison group that unaffected of 1,000 people, and about like 945 people who have COVID and are asymptomatic to compare. We have the ability to compare these different patient groups. It's really quite an opportunity to see what the differences are. Those are the cohort studies. You also have large electronic health record studies going on, and they're the ones that have come up with data most quickly because they have access to about 60 million individuals in the U.S. with health medical records. Unfortunately, the UK is in much better shape because they have access to the National Health Service data. The U.S. would have to kind of put it together, but we have a group that's been able to do that. And so they're often working. And the other thing about that group was that can be set up to look 10, 20 years down the line to see what the effects of COVID are on things like common things like heart attacks or strokes, and maybe even uncommon things like different autoimmune disorders. So that's set up for the long run. Now, the other thing about a condition like this is that you study people who have the disorder and you're stuck with examining, say, blood or urine or saliva, but those issues may not have the answer. So we also have covers an autopsy study. We were looking to talk to the families of people who died for whatever reason. If they had post-acute sequelae of COVID or long COVID, and their families allow their tissues to be examined, essentially we can look, under the microscope at the heart or the brain or the GI tract. And that gives you a really powerful ability to look out. So that's also ongoing. Then we're just beginning now to set up the clinical trials in people with long COVID. So there's multiple different components to the recover initiative. As I said, it was built to be kind of all comprehensive, leave no stone unturned type of study.
Yeah, I mean, it sounds amazing. I mean, the sheer numbers that you just mentioned. I'm sure I spoke to somebody whose name I cannot remember, who was saying that actually a lot of the problem is getting people involved in research and getting the numbers in order to then get the data to look at. So it sounds like you've got a lot of numbers there, which hopefully will allow you to find something useful.
Now, I would just say that that was a really good point that we have now upwards of 14,000 people who've already enrolled in the study. So they're the real heroes, ones who, volunteer to get poked and prodded and get all these tests done. And you think about it, people who have symptoms, they might join because they want to, find an answer to themselves. But also we have a lot of people who have made a great recovery, and they volunteered to out with them. So they're the real heroes.
Yeah, I mean, that's a good point. We were talking about comparing the people with long COVID with the people without long COVID and the people who've recovered. And that's a really good point because, looking at the people who have recovered, what makes them different to the people who haven't? And I guess that's going to hopefully give some answers, isn't it?
That's exactly right. That's really the real goal of the recovery, is see what's different between those two groups. Now, there's two things to think about. It could be that the infection affected them differently, or it could be that they respond differently to the same insult. So that's kind of the two major groups that you'd be trying to understand. And that's, incredibly important if you're trying to develop treatments, to know what it is that's the underlying cause.
Yeah, and that's the $1 million question, isn't it? What is the underlying cause?
Well, there's no shortage of culprits, unfortunately. So it's really a matter of trying to nail down, and it could be different culprits in different people, but there's about four things at the top of most people's list. One is that the virus is still present somehow in the body, and it's still stimulating the immune system, whether it's live virus that's still replicating, or whether it's dormant virus, or whether it's just particles of the virus that just got incorporated into tissues. Well, any of those things could be creating continuous stimulation of the immune system. And of course, it's stimulation of the immune system that is known to cause all these symptoms of long COVID. And then, the other possibility is that there's an autoimmune disorder, because when you do have COVID, your body makes a big immune response, and it produces antibodies and produces cellular response to kill the virus. But we know that that response kind of overflows and causes antibodies against your self-antigen. So normal parts of your body can also be misinterpreted by the immune system as being part of the virus. And that's what we call autoimmunity. Another possibility is that the infection affected the immune system and made it really rev up, and never kind of resets. And that would be an immune dysregulation problem. And then the other one is that it turns out that there are a lot of viruses that we get infected with that lie dormant in our bodies. And when you have an infection of any kind, but COVID similarly, you can get reactivation of these viruses. They start to pop up again.
So I think those are the kind of four leading theories, which, we're trying to track down. And as I said, it could be different in different people.
Yeah, of course. So the same virus, so COVID in this
Yeah.
instance, could have triggered any of those sort of reactions that you just said. Or I suppose even a combination of more than one of them, possibly.
Yeah, no, that's true. Yeah. Yeah, I mean, in the acute infection, all those things happen. The issue is what happens over time after the virus is cleared from your respiratory tract and you're no longer positive on those tests. Which of those four is still, not calming down?
Yeah, definitely. And I found it really interesting what you were saying about being able to track people from literally from date of infection all the way through to say 20 years down the line, which seems a sort of insane amount of time in the future, doesn't it, when you think about it right now? But I suppose having that amount of data would be amazing because I have all of my kind of what am I, almost 3 years down the line now, and I sort of know this happened at this point and this happened at this point, but that's completely unscientific because it's just my stuff. So having this in an actual kind of, I don't know, scientific way for a huge amount of people would be awesome.
Well, I wouldn't discount the scientific value of you as an individual, because the answer is going to be in, a couple of people will basically, who are well studied, will provide the clues. So the initial question is what's wrong? So in your case, what's wrong in you? And then the second question is, how does that generalize out? So an in-depth study in small numbers of people could give clues, but then you need these large numbers to generalize. So you have to kind of hit the problem from all different angles.
Yeah, that's a really good point, actually. Yeah. So the Recover study, I mean, you said that it's running for a long time, but do you know sort of at what point you might start getting, I was going to say answers. I'm not sure if that's quite the right word, but that can start feeding into other avenues of research that might start presenting treatments, perhaps, or something along those lines.
Yeah, no, that's certainly the most important question. As I mentioned, the electronic health record studies have already been producing data and publications. They can look at the demographics, and they noted that it's less frequent after Omicron than Delta. It's less frequent if you're been vaccinated. The chances of developing long COVID are greater if you're more severe the infection is. In our country, racial and ethnic minority groups with long COVID were more likely to be hospitalized. It seemed to be, although the different variants develop different chances of getting long COVID, symptoms though seem fairly consistent across all the patients. Pretty uncommon in children, except if they have a really severe infection requiring an intensive care unit. And the electronic health record studies are coming out because they get their data, from lots of people and analyze it quickly. The more biological studies are certainly taking time, and I guess that some of it's because we spent so much time collecting. Now we have to kind of quit spending more time and money on analyzing all of what we've taken in. We're hoping that we'll get some answers. Certainly, autopsy study, they'll be able to say whether they see anything or not on at one level. Probably not going to be the final level. They'll have to go deeper. Our studies, the cohorts, they're tiered. So the first tier, which what everybody gets, is a fairly wide net type of evaluation. Samples taken. Then if you have a certain set of symptoms, then you move into tier 2, where you get more intensive tests related to your particular problem. There's actually a tier 3 that are even more intensive testing for people who have come out of the tier 2 with some abnormality. So most of what we're doing so far is tier 1 stuff. now, as we pretty much close enrollment, move into the tier 2 and tier 3, which is more intensive study. And then the clinical trials, we have two strategies here. The first is to try to understand if there's something that could hit at one of those four major culprits as the kind of underlying cause. And there, the first thing we're working on to test antiviral agents on the chance that there's still virus present and replicating that an antiviral might help. But then the other strategy is to try to develop treatments for the symptoms. So one is what we call disease-modifying treatments to get at the underlying biology. And the other is symptomatic treatments, which get at how to improve, for instance, the sleep disorder, the postural orthostatic tachycardia, the cognitive troubles, exercise intolerance. Those are all kind of symptomatic trials that we are hoping to get going. And we have basically had groups who have consulted with patients, people who are affected, to understand what the problems are, the most bothering folks. And then we had groups come together, develop what we call master protocols, which would test, the sleep disorders, or a master protocol for the exercise trouble, master protocol for autonomic trouble. And these master protocols would then allow you to test one thing after another in them in sequence or in parallel to try and get answers for people to help with their symptoms. So those two strategies are active now.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Fantastic. Yeah, so you're trying to kind of, hit it from both sides almost, aren't you? Trying to kind of to test the theories on the underlying cause, but also deal with the stuff that you can literally see in front of you. So you mentioned things like POTS and sleeping disorders, just to name a couple. So I suppose you're kind of covering both bases.
Yeah, no, that's the idea. You'd like to have a magic pill that makes everything go away. That gets at the underlying disease, but it's really going on so long now that we don't have that kind of answer yet. So I think it's really important to try and help people feel better. I mean, that's what medicine's all about, is making them feel better, right?
Yeah, exactly. Yeah, the things that you can do to help, they might not fix everything, but if you can make someone feel even 1% better, then, that's 1% better than they felt yesterday. And personally, I would take that.
Yeah, good point.
Yeah, that's awesome. You mentioned earlier, before long COVID came along, the research into MECFS, and it was actually Dr. Avindra Nath's research that I came across first. It was someone else put me onto it. So would you be able to talk a little bit about that? And is that something that might be able to, feed into or enhance or work with in any way some of the long COVID research?
Yeah, so I'll try and do him justice, but very smart, caring physician, scientist. He's the clinical director of our intramural program. So not people know what that is, but the NIH, most of our work is funding science that goes around at the hospitals and universities around the country, but there's also laboratories, and there's actually a research hospital here on the campus in Bethesda. And it's the largest research hospital in the world. And the people who are here they are federal employees, and they're here only to do research. So when we were first involved in ME/CFS research, Dr. Nath started a protocol to do intensive study in small numbers of people with ME/CFS to see if we could get at the underlying troubles. And, he basically designed the tests, designed, what samples to take, and then now has been analyzing those samples. And I think he's coming to the point where he'd be able to publish his results. I don't actually have those results myself. He's still working on it. But then when COVID came and post-COVID came, he basically took that same protocol that he had used for ME/CFS, maybe a couple of modifications, but not much, and then enrolled people who had long COVID into that protocol. And so that's going on now. And there's a somewhat similar syndrome called Gulf War syndrome that occurred in the veterans who went into that war in Kuwait. And that has ME/CFS-like symptoms, long COVID-like symptoms. So he's also working with the VA, studying patients with that condition. So the advantage of Dr. Nath is he has all this experience. He's actually a neurovirologist, so a specialist in viruses that affect the nervous system and neuroimmunology. And so he's looking at these three different conditions which have, some overlap in their symptoms, trying to see if there's something that falls out when he looks at them in toto.
Yeah, and that's fascinating. The kind of, I don't know if we call them related conditions. I'm not sure what the sort of slightly more scientific word for it, but all of these conditions, they have so much in the way of crossover, don't they? And
In terms of the symptoms, yeah.
yeah, and I sort of, when I was starting to look into long COVID and long COVID research, and and it's also over my head because I'm not a scientist, but realizing how, I'm not sure if useful is the right word, but certainly if you looked at research into ME/CFS, and if you looked into what people might have found to help them, actually a lot of them is very similar to what is helping personally me with long COVID. So it's really interesting, isn't it?
You can't let any clue, not get followed up. You're right. Yeah. So what do you think is helping?
For me, the most helpful things have been training my breathing,
Yeah.
yoga nidra, for sort of the deep rest kind of thing, and actually cold swimming. So I live quite close to Loch Ness, so I've been dunking myself in there, and I found that to be the most useful thing that I found so far.
Okay, well, that's interesting. Yeah.
So I don't know if that's any use for you, but
The exercise protocols, I was just looking at them the other day, and so breathing exercises are a big part of that, and trying to get more coordination between the breathing and the exercise to see if that will help.
yeah.
So yeah, people I know, there's a little bit of upset about exercise therapy, but it's really we're trying to do things to allow people to be more functional in terms of being able to do more quote unquote muscle work. But we do have to be very careful. I know you probably know from ME/CFS patients that there's a condition called post-exertional malaise, where they become very sick after exercise. So that's built into the protocol. There's these different tiers, in terms of exercise. If you develop any signs of post-exertional malaise, you don't go to the next step. You stay at the easier level. So we are paying real close attention to that. But then in some people, COVID affected the lungs and they still have kind of trouble with their breathing coordination. Some still have persistent cough. So the pulmonary part of that is also important for some people.
Yeah, and then you mentioned earlier, the long COVID, but also post-COVID complications. And I think these terms are used kind of interchangeably, aren't they? And I'm not sure if that's a good thing or not. But, long COVID is such a kind of umbrella term that covers so many different things. I suppose it makes it quite difficult to study it in some ways, doesn't it? If you're looking at somebody who has actual physical organ damage, and also somebody who has post-exertional malaise and fatigue and things like that. That they're two quite different things, but are they related? And I guess that's what we're trying to work out, isn't it?
I think, that's the issue with long COVID. It's, the number of symptoms that occur in long COVID, the estimations are sometimes over 100. Most conservative are about 70. I think that's what we saw in our studies, almost about 70 different symptoms, and they occur in clusters. So nobody has one symptom. They generally have 7 to 13. But there are these little groups that we found. We found an autonomic group, we found a cognitive group, we found an exercise trouble, breathing group. And then some people have sleep disorders, some don't. Sometimes some sleep disorders, people can't sleep. Some sleep disorders, they're sleeping too much. So there's a lot of variability, you're right. One thing to caution people, though, is that the symptoms in long COVID are very common occurring without COVID. So some of the studies that you ask people, well, do you have fatigue? And you look at the people who had COVID and you get a certain percent of people have fatigue. If you ask people who don't have COVID if they have fatigue, a certain percent are going to say they have fatigue. So they're very common symptoms. And one thing to really be careful about is not to blame everything on long COVID before you know that there's not something else going on, because the symptoms can be caused by a lot of other things. So if you are, say, you're hypothyroid, your thyroid isn't making enough hormone, you're going to feel fatigued, you have sleep trouble, probably sleep too much, I guess, and you can't exercise. And if you had COVID, the obvious thing, oh, I must have long COVID, but no, you have hypothyroidism and, you need thyroid hormone and you'll be fine. So really important to lesson to people is to, when they're having these symptoms, talk to their doctor and just get checked out that there's not something else going on, for sure.
Yeah, definitely, because some of these things actually can be treated.
Yeah.
And I've definitely noticed people talking about things. I'll use your example of hypothyroid that actually has been triggered by COVID, but it's something that could actually be sorted. So I suppose that's the same warning, isn't it? Get it checked out, because
Yeah.
you might be able to do something about it that will at the very least help.
And most thyroid conditions in adults are autoimmune in their nature. So whether it was started by COVID, hard to know. But again, the treatment is pretty standard and not to miss it.
Yeah, definitely. So we've talked about Recover and we've talked about Dr. Nath's research a little bit. Is there anything else going on in the sort of long COVID research arena that you're kind of involved in?
Well, I think in the US, at NIH, we're a government agency. And so we work with multiple other government agencies. And so the Department of Health has basically a task force on long COVID, which involves people from, education, because there's kids involved, disability, because some people can't work, Medicare in terms of payment. So in the US, you get paid based on what's called billing codes, and it's now a billing code for long COVID. So a lot of work going on at the different agencies. The Veterans Administration in the US has pretty close to what you have in England for your population. They have for the veterans in terms of electronic health records. So they've been able to do some really good electronic health record level studies. So yes, there's a lot going on in this space, and I think we got to keep pursuing it to try and get relief to people who are still suffering.
Yeah, definitely. And you've just mentioned a whole load of things, but including finance. And one of the things that you see it all over social media all the time, the way people are struggling. They have long COVID and they feel terrible and they can't do things, which is terrible. It's awful. But on top of that, they can't work. So they can't maybe afford medical care, or they can't afford their houses. They can't afford to eat. So it's not just a medical problem, is it? It's a
Social.
very wide-ranging social. That's exactly the word. Yes, that's what I was looking for.
No, absolutely.
So yeah, it's huge.
The people who listen to you and give you input, I think that's also critical to know what's happening out there, particularly to know, how things go over time, because most of the studies were looking at people. At first it was like 3 weeks after COVID, then it was a month after, then 3 months. But now we have people who are out 2 years. So to find out, how they're doing, I think is also really important now.
Yeah, definitely. And I suppose that's where your sort of patient input comes, isn't it? And
Yeah.
that's something that I've noticed, again, coming from my background of absolutely not medical whatsoever, and coming into this kind of space of looking at research and what it means. And I had not really realized that patient involvement in research was even a thing, let alone how important it was. And that's definitely really opened my eyes to that. And you mentioned that you'd got patient involvement. I can't remember which bit of the study it was that you mentioned, but you said you'd had input from patients. And how helpful is that? I mean, it must be vital.
Yeah, well, certainly for long COVID, it's all about a new condition, maybe not entirely new, but it's now post-COVID is new. The ME/CFS is unfortunately not new. But I mean, certainly if you're going after symptoms, the key thing is to know what symptoms are most important. In neurology, for instance, there has been studies where the doctors have a rating scale on how people are doing. The patients have their own sense, and sometimes they don't match up. So certainly when you're going after symptoms, you have to know what's most important to people. And then in terms of, doing these studies, you have to know that you're not overburdening people with all the testing so that they can't participate, or it's too onerous for them to participate. So yeah, having patients at all different levels, particularly in kind of design, when you're designing things, because sometimes the doctor's sitting around a table, they have this wild imagination and they think people can do anything, but in real life you have to test it out and find out what's really going to work in the patients you're trying to help. So have people at the design level, and then also have patients or people with lived experience, as you try to adjust, because whatever you do in the beginning, it's not going to be perfect. You have to keep looking and improving your research protocols. And so getting that kind of input is really important. And then I think getting the answers out to people is also really important. And so doctors are usually not the best communicators in that space. So if you want to tell people who have long COVID, what's going on in the research and what it means to them, the best people to help you with that are people who have long COVID. So.
Yeah, that's a really good point, actually. Yeah. And it totally takes us full circle back to what you were saying earlier about the point of medicine being to help people to get better. Well, thank you so much for joining me today. It's been an absolute pleasure hearing about everything that's going on. So thank you so much for taking your time to do it. And perhaps you'd come back and talk to me in the future when you've got some results.
Oh yeah, happy to do so. And yeah, thanks for the work that you're doing for the community. Appreciate it.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch